Although bladder cancer is one of the more common cancers, most people know less about it than other types, such as breast cancer or prostate cancer. While the majority of bladder cancers are quite easy to treat, the more aggressive or advanced forms of the disease need to be treated in a specialist centre like the one at Addenbrooke's Hospital in Cambridge. Dame Mary Archer was chairman of Cambridge University Hospital's NHS Foundation Trust from 2002 to 2012.
Being diagnosed with bladder cancer is a shock for anyone. Although, of course, I already knew quite a bit about the excellent urology services at Addenbrooke's Hospital, I never thought of bladder cancer as something that would happen to me. But in 2010, it did. There's a lot to take in, and your life changes very suddenly. There are tests and examinations to undergo, followed by anxious waiting for results, and then there might be some quite difficult decisions to make about your treatment. Our team at Cambridge University Hospitals has made this DVD for you and your close family and friends if you've been referred to Addenbrooke's for high-risk bladder cancer. You might also find it useful if you're being treated elsewhere, although you should always talk to your own doctor about the most suitable treatment available for you. We're very grateful indeed to the many people who've helped us in the production of this DVD. And I'd specially like to thank the patients, past and present, who so willingly shared their experiences. The project was supported jointly by the Urology Department here at Addenbrooke's, ACT, which is the fundraising charity for Cambridge University Hospitals, and the Anglia Cancer Network, and we're very grateful to them too.
The Anglia Cancer Network coordinates services for patients with bladder cancer in Norfolk, Suffolk, Bedfordshire and Cambridgeshire. Patients are cared for in 10 local hospitals across the Anglia region, with more specialist services and overall coordination provided from Addenbrooke's and the Norfolk and Norwich. When you are diagnosed with bladder cancer, you need to have an agreed plan setting out how the right tests and treatments will be provided for you. These plans are put together by a multidisciplinary team, or MDT for short. The MDT is made up of top clinical experts in the diagnosis and treatment of bladder cancer, working together to design the best plan for your care. However, you are also an expert. You are the best possible expert about your own wishes and preferences. We want to make sure that you are able to get all the information you want about your condition and the plan for your care. We also want you to be able to take part in decisions about your treatment so your plan can reflect your own wishes and preferences. We hope that this DVD and the website will help you do this.
The role of the Anglia Cancer Network has now been adopted by the East of England Strategic Network, which covers the wider geographical area of the old Anglia Cancer Network, the Essex Cancer Network and the Mount Vernon Cancer Network. Actor Ruth Maddock is well known for her television, radio and stage appearances, including the roles of Gladys Pugh in the BBC's Heidi High and Mrs. Thomas in Little Britain. Ruth was diagnosed with bladder cancer in 2005.
For the majority of people with bladder cancer, the diagnosis comes as a complete surprise. My bladder cancer was diagnosed when I went for a routine checkup. I hadn't even noticed any symptoms, and I looked and felt really well. It's a frightening and confusing time, and you're very quickly propelled into an unfamiliar world of regular hospital appointments with all kinds of tests, scans, and examinations. I think of myself as a strong person. I've been in tough situations before. But no matter how strong you are, this is a difficult time. And with treatment for bladder cancer, you're starting out on a journey. You need all the help and support you can get. And while your doctors and your named specialist nurse will support you every step of the way, you sometimes need to sit quietly by yourself or with someone close to you to think things through, to get it all clear in your head. Now, this DVD and website have been made to help you navigate your journey. I hope it'll help you and those close to you to understand your bladder cancer and to take back some control at every stage of your treatment.
Actor Ian Lavender was diagnosed with bladder cancer in 1993. He has appeared in many popular TV series, films, plays and musicals, and is best known for his roles as Private Pike in the BBC's Dad's Army and Derek Harkinson in EastEnders.
When I was told that after 20 years my bladder cancer had returned and that now the only chance of a cure was to have major surgery, it was hard to make sense of it all. Although everything was explained to me, I don't think that back then I was really prepared for the changes that would take place in my life. The hospital environment and the process of coming in for appointments and scans was quite frightening. And the questions I wanted to ask didn't always occur to me until I got home. But one thing I did learn was that it was always better to ask, and that the more you learn about your condition, the easier it is to cope. The medical team at Addenbrooke's Hospital will try to ensure that you have all the professional help and advice you need, and they're always willing to answer your questions. For a large part of it, you have to put your trust in their skills and expertise, but it's important for you to understand what choices you have and the impact each type of treatment is likely to have on your life. So the information in this DVD and the accompanying website will help you to make sense of the complicated tests and procedures you may have to go through, as well as the decisions you'll have to make about your own treatment. I hope it makes those decisions easier for you, and I wish you the best of good fortune in facing the challenges ahead.
We have designed the DVD to be used in conjunction with the Addenbrooke's Bladder Cancer website, where you will find extensive details of the services for bladder cancer and links to other trusted sources of information for you and your family. We have designed the website so that you can easily print out sections of it if you would like to. There are different ways to watch this DVD. You can watch it all the way through to learn about the different types and stages of bladder cancer and the treatments available. Not all of it will apply to you, so the DVD is also divided into chapters so that you can start watching at any point and select the sections that are most relevant to you. It's probably best to start with the explanation of what bladder cancer is and what the types and stages are. Keep the DVD and watch it again at different stages of your assessment and treatment. You'll probably find it helpful to watch it together with a close family member or friend. Part 2 contains further discussions by our consultant surgeons to help you with some of the key decisions you may be faced with. If at any time you don't understand something or have any questions, there are always people you can speak to. Your main contact will be your named specialist nurse, who will either answer your questions or put you in contact with someone who can help you. There is a list and contact details of people you can speak to in the support section of the website, as well as links to other recommended sources of information and advice. Remember that no two people's cancer is the same, and everybody responds differently to treatment. We've tried to give you, here and on the website, as much information as we can to help you prepare for making decisions about your treatment. But you won't be doing that alone. Your doctors and other members of the team look at all the medical evidence before discussing with you how best to proceed. At all times, our aim is to ensure that you get the best available treatment to suit you.
Well, when I was told I had cancer, at the time when he told me, I just shut down. Whatever I was told, I didn't hear anything. So obviously it came as a shock.
If I got a DVD and could have gone back and looked at what we discussed, this is where I take my wife. We both go together with their problems. The second pair of ears at the moment. The DVD will take that second pair of ears out, although she'll still want to come to know what's going on.
Bladder cancer is the 7th most common cancer in England. Around 11,000 people are diagnosed with bladder cancer each year, with around 450 new cases each year within the Anglia region. Mr. Robert Mills is a urologist who specialises in bladder cancer treatment at the Norfolk and Norwich University Hospitals NHS Foundation Trust.
We tend to talk about bladder cancer as though it's one disease, but it's better to think about cancers of the bladder as a range of different diseases that require different approaches to treatment. No two cancers are the same, and no two people respond to treatments in an identical way. So it's important for us to know as much as we can about your cancer so that we can treat you in a way that gives us the best chance of success and is most appropriate for you.
Bladder cancer is a very big spectrum of disease, from things at one end of the spectrum that are very favourable, so small growths that just need to be scraped away, and then at the other end of the spectrum there are much more aggressive forms of bladder cancer that need to have more aggressive treatment.
The bladder collects urine from your kidneys, which filter waste from the body and adjust the amount of water in the blood. When the bladder is full and you have the sensation to pass urine, your bladder will contract and empty through the water pipe or urethra. The bladder wall is made up of several layers that help to give it strength, as well as allowing it to stretch and protecting it from urine. For diagnosis and treatment purposes, we separate bladder cancer into categories according to 3 general headings: type, grade, and stage. There are 3 main types of bladder cancer. The majority, around 95 in every 100, are known as urothelial. Urothelial cancer used to be known as transitional cell carcinoma, or TCC. The 2 rarer types are squamous cell carcinoma and adenocarcinoma, and they make up between them about 5 in every 100 bladder cancers. The second way in which we categorise bladder cancers is by grade, which is a measure of how aggressive the cancer is. The 3 grades are grade 1, the least aggressive, grade 2, which is moderately aggressive, and grade 3, which is the most aggressive. We assess grade by taking a sample of cells from abnormal areas of the bladder and examining them under a microscope. The third way in which we categorise bladder cancers is by stage, and this tells us how far the cancer has spread through the layers of the bladder. Each stage is given a number to describe how far the cancer has spread through the connective tissue, muscle, and fat layers. In the most advanced stages, the cancer will have spread outside the bladder and may involve other parts of the body, such as the prostate in men or the womb or vagina in women. In stage PTA, the cancer cells are confined to the surface lining. In stage PT1, the cancer has spread to the connective tissue layer between the surface lining and the muscle wall. In stage PT2, the cancer is within the muscle wall. In stage PT3, the cancer is through the muscle and into the fat layer around the bladder. In stage PT4, the cancer has spread outside the bladder and into an adjacent organ. Carcinoma in situ, PTIS or CIS, is an aggressive or grade 3 form of cancer that is confined to the surface lining of the bladder, and its growth pattern is flat rather than raised.
There is more information about the different types, grades and stages of bladder cancer on the website, where you'll also find a glossary of terms. So that we know as much as possible about the type, stage and grade of your cancer, we will ask you to undergo a number of investigations. By gathering all the evidence we can about you, we can plan your treatment specifically for you. We will take small samples of your blood for different reasons. Measuring the numbers of different types of blood cells can give us a picture of your general health, and by looking at the chemical makeup of your blood, we can see how well your kidneys and liver are working. The first important examination for us to do is usually to look inside your bladder with a kind of telescope called a cystoscope. During this examination, your doctor will take some tissue samples, called biopsies, from the abnormal area in your bladder, including the muscle wall of the bladder, and also from the water pipe or urethra. These will go to the laboratory for microscopic examination.
In the laboratory, we process the tissue samples and cut very thin sections, which we then examine down the microscope. First of all, we look at the architecture of the tissue to determine whether it is a tumour or not. We then look at the cells in more detail, and depending on how abnormal they look, we then decide the tumour grade. We also look at how deep into the tissue the tumour cells grow in order to decide the stage. All of this information is then put into a report, and we discuss our findings at the MDT meeting.
I had a test, I think it was called a cystoscopy, where they looked inside my bladder. And the chap who looked said, "Oh, there's a tumour in here."
The same day I was here and saw the gynae consultant, he arranged for me to have a flexi cystoscopy. So I got a diagnosis all in one day.
Local anaesthetic, just went and they put a camera up the penis and to have a look inside the bladder to see if there was anything wrong.
So I came back later and they did a biopsy, sent off for some tests, and it was the very aggressive one.
From that camera, they found a small growth on the inside of the bladder, and that obviously then went away for analysis, and it came back saying it was cancerous, but not aggressive.
At the same time as the cystoscopy, we will carry out an examination of the mobility of the bladder, sometimes called an examination under anaesthetic.
We need to do an examination of the bladder whilst you're asleep, and this is to assess the mobility of the bladder to help decide how feasible it would be to remove the bladder in an operation. That's a procedure that would need you to come in to hospital for the day.
Yes.
Takes about 10 to 15 minutes to do. We look into the bladder with a camera, and then we assess the mobility of the bladder by examining you whilst you're asleep.
Is that a local anaesthetic I have?
So that would be done under general anaesthetic, but you would almost certainly go home from hospital on the same day.
Yeah,
so it would be a day case procedure. But depending on what kind of treatment you opt for at a later date, we do sometimes take some biopsies from what's called the bladder neck to help try and plan, if you were to have surgery, whether you would want to have a reconstruction or formation of a urinary stoma.
Another important examination that we may do, unless you have already had one, is to do a body scan of your bladder. This is often a magnetic resonance imaging, or MRI scan, and sometimes a CT scan. An MRI scan uses powerful magnetic fields to take cross-sectional images of your body. It can help to show how far the cancer has spread through the bladder wall. Sometimes you'll have an injection of a dye called a contrast medium to help make the images of the bladder clearer.
Well, the MRI scan is pretty straightforward. You just lay down and you don't need to be claustrophobic, but apart from that, you go very slowly into this tube.
We may do a CT scan of your bladder instead of or as well as an MRI scan. A CT or CAT scan is a specialized series of X-rays that are built up by a computer into a three-dimensional image of your bladder and the surrounding area.
And while we do the scan, we'd like to give you an injection of a dye that's just going to help to show up all your kidneys and bladder. Is that all right with you?
Having the CT scan was no big deal. I guess it could be a bit frightening. It's a big room. It's not one of these tunnel scanners. You do lie on a bed, but it's just a big ring that the bed moves through and back again. The nurse was very good at explaining what was going to happen. You have an injection of dye, contrast dye. That has a most peculiar effect. It makes you feel as though you've wet yourself, although you haven't. And you get a metallic taste in your mouth. But they explain everything as it's going along. It doesn't take very long at all. They give you instructions over the intercom if you've got to breathe in, hold your breath, or what have you.
In some unusual circumstances, patients have a whole-body bone scan to discover whether the cancer has spread to their bones. A small amount of a mildly radioactive liquid is injected into your arm, but don't worry, it's quite safe. The level of radioactivity is too low to cause you any harm. It takes up to 3 hours for the radioactive substance to reach all parts of your bones. If there are any abnormalities, they will show up as hot spots on the scan.
The worst part was when we went back to find out exactly how far it had gone, and we were made to wait for quite a while, and the longer we waited, for me, the more I was thinking this is not good news.
Certainly had some anxious moments, but at the end of the day, you know that you're going to be dealt with and something's got to happen, so you live with it. But it was quite a difficult period, I remember, yes.
The consultant, he told us very, very nicely and explained everything and said where we were going to go on, and we came out of there completely numb.
We understand that waiting for your test results can be an anxious time. We will try to ensure that we will let you know as soon as possible what we have found, and this may take around 2 weeks. However, if you have any questions or concerns in the meantime, you can talk to your named specialist nurse. Every patient who comes to the clinic is given as much time as they need with the consultant or the registrar, which is normally between 30 and 60 minutes, although you could be with us for up to 2 hours on occasions.
We have a team of administration staff that work in the urology clinic. We also have a bookings team, so if a patient has a concern or a query about their appointment date or time, then we can change that and look to reschedule for them. Patients will bring with them an appointment letter, and in that appointment letter it will have instructed them whether they need to complete any charts that may be relevant for their appointment. They may also be asked to bring in a urine sample for their appointment. We have our consultants, our registrars and our specialist nurses, and you may see one of those or all of those depending on the situation on the day. If a patient needs to contact any member of the team, they can do this via telephoning the receptionist, and the receptionist will liaise with the relevant specialist in order to get the information that you need.
Your urologist, together with other colleagues, including doctors, nurses and other specialists, meet regularly in an MDT, or multidisciplinary team meeting. This takes place at Addenbrooke's Hospital, but includes experts who join by video link from across the Anglia Cancer Network. During the MDT, all the results of your tests and examinations are discussed so that we have the best possible overview of your cancer and the treatment options suitable for you.
Hello, I'm Bill Turner. I'm one of the consultants. How do you do?
I'm very pleased to meet you.
Your urologist will see you as soon as possible after the MDT meeting, ideally within a week or so, to explain the nature of your cancer and what that means in terms of the treatments we can offer.
So what we've found from the biopsies is that this is an aggressive tumour, and it's gone through the surface lining of the bladder, not into the main muscle wall, but into the layer in between the lining and the muscle wall, what's called the connective tissue layer.
All treatments will have some side effects, some short and some longer term, and it's important for you to understand what the benefits and the side effects of each treatment would mean for you in practice, so that together with your clinical team you can make the choice of treatment that best accords with your values and preferences.
And when I saw Mr. Turner, I said, but I've got to be back in work in 3 weeks. And he said, right, we're going to try and make that happen, Ruth.
But so this was a gradual process, and eventually, I was now into a full-scale long-run production in the West End, and this looks as though it is. We tried BCG treatment and didn't work. I was having the treatments whilst working all at the same time. And the surgery was then planned, and it was planned for when I finished in that show.
the tests came back positive to say that yes, it was this awful one, and I would have to have my bladder removed. But there are various options. I mean, I've chosen to go for the bag because I wanted to get back to work quickly.
I weighed up the pros and cons. It's a very difficult decision to make. You've got the option of BCG treatment, which isn't guaranteed successful, and potentially has unpleasant side effects as well. Or the surgery, which is risky, and you obviously then have to choose reconstruction or having the stoma in a bag.
It's one of the reasons why they did an MRI scan to determine how the cancer was laying, but to also to see whether they could save my reproductive organs. And to be told a few days later after the results came in that yes, they thought they'd be able to save them was absolutely incredible. I just felt like I'd gone from such a dark place of not being able to be a mum to now knowing there's a really good chance that I could still have a child.
We know that bladder cancer is more common in smokers. The chemicals in tobacco smoke that cause bladder cancer go through your bloodstream and into your urine, and with constant exposure from years of smoking can cause changes to the cells of the bladder lining. The good news is that even after you have been treated, the likelihood of your cancer returning is reduced if you stop smoking.
When I was first diagnosed 20 years ago, yes, I certainly did go, why me? My age. I mean, Nigel said it's very rare in somebody your age. And there he was, puffing on his pipe, saying, well, of course you're a smoker. Yeah, he said, well, it's not coincidence that more than 50% of my patients smoke.
I used to be a smoker, yeah. I used to smoke cigarettes in my early days, and this last 20 or 30 years I've smoked a couple of cigars a day.
So for 12, 14 years, I smoked perhaps 20 a day. I lived in Africa. Cigarettes were 2 pence for 100, relatively speaking. And you smoked. It was the 60s. It was cool. It was in, and I enjoyed it.
It has been shown that people who are supported by the NHS are 4 times more likely to succeed in quitting than those trying to give up on their own. Ask your doctor or specialist nurse to refer you directly to free local NHS support. We also know that people who have had long-term exposure to chemicals such as paints, dyes and rubber have a higher than normal risk of bladder cancer. If you think you might have been affected by exposure to any type of chemical, even if it was many years ago, you might be able to claim industrial injuries disablement benefit. You can find out whether you are eligible to make a claim by looking at the Department of Works and Pensions website. Other general health issues could have an effect on the type of treatment that will work for you, so you should maintain a healthy, low-fat diet and undertake regular, gentle exercise. We will assess your general health and may refer you to other specialists, for example, a heart specialist or a breathing specialist, to help get you ready for future treatment. During this time and throughout your treatment, it's important to have the support of the family and close friends around you. The more they know about what you're going through, the more they can help you. You might want to watch this DVD and look at the website together with someone in your family or a close friend. Sometimes you may want to speak to someone outside your family, and your specialist nurse can help you, put you in contact with other sources of support.
Addenbrooke's Hospital did with me, and I'm sure they do it with other patients as well, is they give you what I call a buddy, and you get a phone call from somebody or from 2 people, one who's had the stoma on obviously the way I've had mine, and then someone who's had the reconstruction as well. So you get a chance before you make up your mind to talk to these 2 people. You listen to what they got to say, and then obviously you make up your mind which way you want to go.
Before I had the operation, they referred me to a guy who'd had the operation about 5 years before,
And I spent time with him and saw his stoma operation and whatever, you know, and it was quite encouraging to see somebody who had it 5 years before and still looked as well as he did, you know, so that was quite a plus to do that.
Talk to people. I've been back to the hospital talking to people in early days that were a bit concerned about it. I met a chap with his wife soon after I had it done, and just talking about it helps.
And I then did the same thing for another guy after I'd had my operation, you know, so it passed down the line, you know, of helping other people along.
And the important thing is for a partner to go to all the appointments and consultations, ask as many questions as you can, and talk about it, and that helped.
You just don't absorb everything they tell you in that 8-day period that I had in hospital. There's an awful lot to absorb, an awful lot to learn, and you face it when you come out step by step, and you conquer each step in your own way.
The whole process was one of, what do you want to know? What don't you understand? Ask us. Let us tell. We're on the phone. Think of something when you get home. Give us a call. You want to come in again and have another talk? There's Sister Wendy, Sister Nicola. They're all there for when you want them.
The support I got was absolutely tremendous, and therefore I felt relatively comfortable with everything that was going on, because they were there. They were there for you, and they did. They said, "Oh, you know, do you want to talk?"
Once we've established as far as possible the type, stage and grade of your tumour, the range of options for treatment is usually quite clear. Most of this information comes from the original telescopic surgery to remove the tumour. This is called transurethral resection, or TURBT. We know from experience, and there is some evidence from scientific study, which types of cancer are most likely to respond to chemotherapy and which require either surgery to remove the bladder or radiotherapy to destroy the cancer cells. However, no treatment is completely successful in every patient, and all treatments have risks of side effects. To decide what is the best course for you at each stage of your treatment, your urologist will discuss with you the benefits, risks, and side effects of each type of treatment and recommend the treatment or treatments that are likely to give the best outcome for you, so that you can decide how you wish to proceed.
To help try and decide what to do, I think we have to think about what is the risk that's posed by your original disease. When you get a tumour in the bladder, one of three things can happen. The tumour can be removed and then it doesn't come back and causes no further problems. Alternatively, you can get something that's called recurrence, which is where the disease comes back in the same form as the original tumour. So in your case, as the grade 3 stage T1 tumour that you had originally. The third thing that can happen is something that's called progression, and that's where the tumour comes back in a more aggressive form, and we usually take that to mean comes back in the muscle wall of the bladder, and that's something that we want to try and avoid.
After the diagnosis that it was an aggressive tumour and I got to hopefully choose treatment, many sleepless nights, I think that's quite inevitable, chewing over what the options might be, what the future might hold. It was really quite a weight off my mind once I'd decided on surgery, even though that was quite a big undertaking. I looked on it, that was a positive project to move forward on.
These are very difficult decisions for most patients, and this may require time, but you may well feel that your sense of urgency to start treatment is very strong. To help with the tension between the time needed to come to a good decision and not delaying treatment, You will be given clear advice about how soon a decision should be reached, as well as help in making your decision. There is further advice in Part 2, as well as on the website. You might also find it useful to look at the online NHS decision-making information tool for bladder cancer.
The results from your operation unfortunately did show that it was an aggressive type of tumour, so a grade 3, but that it hadn't grown into the muscle wall of the bladder and was in what we call the connective tissue layer, and that's what we would call stage T1 disease. What that tells me is that there is some risk posed by this type of tumour in terms of, firstly, will it come back in the future? And secondly, if it were to come back, would it come back in a more aggressive form involving the muscle wall of the bladder?